Hello, welcome to our Anti-Violence Symposium, brought to you by the 100 Black Men of Atlanta, in cooperation with the Satcher Health Institute and Morehouse School of Medicine and the King Center. We have assembled experts in science, public health, and the community to address conflict resolution and gun violence. Our objective for the symposium are to present research data to show that gun violence is a public health issue, call for a national designation of gun violence as a public health crisis, and create a database of existing violence prevention organizations and make the database available to the public. Our presenters and panelists include Dr. David Satcher, former U.S. Surgeon General, Dr. Mark Rosenberg, past president at the Task Force for Global Health, Dr. James Mercy, Director of the Division of Violence Prevention at CDC's National Center for Injury Prevention and Control, and Dr. Joseph Sakran, trauma surgeon and policy advisor at Johns Hopkins University. We want to thank our committee members, including our co-chairs, Larry Johnson and Angela Kessler, as well as Richard Byrd and Joshua Byrd for their dedicated service to this project. We also thank Georgia Power for their generous sponsorship. Your continued support of our programs and our community is greatly appreciated. For more information or to contact your elected officials to encourage them to support this initiative, click the links in our description below. This presentation was brought to you in part by the 100 Black Men of Atlanta, our members and community partners. None of this would happen without your generosity, service, and support. We want to send a special shout out to Dr. George French and the staff at Clark Atlanta University for hosting us. We look forward to your feedback in the comments below. And remember, please share this content with your family, friends, community organizations, and legislators. Once again, thank you for watching.
Well, this gives me a chance to say something about David. David came to CDC as the first African-American director of CDC. And if you don't really know David Satcher, I'll just say a few words. David Satcher embodies love. I had a friend who died recently named Paul Farmer, who was a giant in the area of global health. And Paul Farmer told me he taught at Harvard, and he said if he ever mentioned the word love at Harvard, where science is worshiped, he could be fired. He said Harvard has declared love a four-letter word. And if you think it was easy for David Satcher to bring the notion of love into this bureaucratic HHS agency, it was not. It was not easy, but he really transformed that place and then went to Washington, where he transformed the office of the Surgeon General. And it has been my privilege to know and to work for David Satcher, a privilege of my life. David, thank you for everything, and thank you for who you are. I feel privileged to be here with all of you, and my thanks to 100 Black Men of Atlanta, my thanks to Valerie and to Morehouse School of Medicine, my thanks to the King Center, and my thanks not only to 100 Black Men of Atlanta, but to 1 million Black women of Atlanta. Yes, thank you. And 2 million Black children of Atlanta. Boy, do we owe you a debt. 100 Black men, 1 million Black women. This city owes you such a debt. So it really is a privilege to be here and to be able to speak with you. I want to start, and I changed the name of my presentation. It was going to be Guns, a Love Story. I want to focus on guns. I've been focusing on guns for 40 years. And I will start out by a poem, if I can remember it. It came from Ireland. The poet laureate of Ireland was talking about the troubles in Ireland, where the Protestants and the Catholics were fighting for 30 years. And during those 30 years, there were lots of people killed and lots of children killed. There were 3,500 people killed in a small country, a very small country. And The poet laureate wrote, he said, think of the children inside the coffins, see their faces. 30 years of fighting, all those years of disgrace. Think of the children, picture their faces inside the coffin. They're very moving words of someone who stopped to think about what they were doing. And he said, think of all these children. 3,500 people were killed. In the United States, it's not 3,500 people who are killed. It's more than 35,000 people every single year. Every single year, 35,000 people. And it's something that doesn't have to go on. It shouldn't go on. We do have a public health approach. We have science. And this science has gotten us out of much, much worse problems. Science helped us eradicate smallpox. Many of you don't even know what smallpox was. It's a horrendous disease. Shortly after you're exposed, you develop a rash and pustules all over your body. And it is the most painful thing because you have pustules on your face, in your ears, on your genitals, all over. And literally your flesh is rotting while you're still alive. It's horrendously painful. People said you could tell if there was smallpox because you could smell it there. In the last century, the 20th century, more than 300 million people died from smallpox. And now the disease has been eradicated thanks to science. It's gone. Science helped us reduce heart disease to such an extent that the cardiologists were going out of business. Cancer. We have cures for cancer and treatments for cancer that we couldn't imagine. President Carter had melanoma that was metastatic to his brain, and he was treated with immunotherapy, a total cure, totally cured, a disease that would have been fatal. So cancer, heart disease, smallpox, measles, polio, science has done extraordinary jobs. We've saved millions and millions of lives around the world from tobacco-related diseases. And so the idea that science can get us out of this is not a strange idea, but we are in a position where we have so many deaths. So the name that I gave to this is, this high conflict is taking an intolerable toll. And we'll see who bears this toll, but a high conflict, I'll explain it as we get to it. We're stuck basically where the people who believe in gun rights are fighting the people who believe in gun control and gun violence prevention. And a high conflict is one where people lose sight of what the goal is. The goal is to save lives. Thanks. That is the goal. And we're stuck here. We are stuck. That's my point here. And it is time to act. Goethe said, knowing is not enough. We must act. Willing is not enough. We must do. Next slide is the poem. Think of the children behind the coffins, look sorrow in the face. All those 30 years, the years of disgrace. This is about the troubles in Northern Ireland. And I basically went on to say that science has saved so many lives from really big problems. It also saved lives from motor vehicle injuries and deaths. But in this area, we weren't applying science to solve the problem. As a result, the United States and our gun violence death rate, as you can see here, it's off the chart. You can't fit it on this graph with many other developed countries and their rates. So the top line is United States. And then you see Chile is the next highest country that ends before the end of the graph. But the rate in the United States doesn't even fit on this chart. It goes on, the next slide. and on, the next slide, and on before it ends. And the reason is we're not doing what we can do. We have this really powerful tool of science, but we weren't using it to address gun violence. How did we get to this point? How did we end up in this predicament here? Well, in 1983, the director of CDC at that time, Dr. Bill Foege, said people are not dying from infectious diseases anymore in the United States. That's not the big killer. People are dying from chronic diseases, heart disease, diabetes, cancer, stroke, and they're dying from injuries, things like violence, intentional injuries, and unintentional injuries like car crashes. He said, we have to do something about this. And he invited us to start a program that would look at violence as a public health problem. And there was someone already there at CDC in 1983. He's your next speaker, Jim Mercy. We talk about the government and some of the problems of bureaucracy. It can be slow to move, but you have an extraordinary resource in CDC and a lot of very, very committed people who can solve this problem, who are deeply committed to solving this problem, if only the government would let them. So he said, let's start looking at violence as a public health problem. This was in 1983. And the public health approach has three pillars. The first is it's based on science. We want evidence. This is a cause and effect world. Things happen for reasons and causes, and we can use science to look at the relationship between the causes and the outcomes. And if we can understand that, we can change the outcomes and we can change them for the better. This is based on science. We don't need to see me. Thanks. The second part is it's focused on prevention. It says, yes, we need to take care of people once they're injured. And you'll hear a fantastic speaker, Joe Sakran, today, who actually has to leave to take care of people who are injured. He's a trauma surgeon. Yes, we should take care of people, but it's so much better if we can keep them from being shot in the first place. Let's focus on prevention. That's the second pillar of the public health approach. And the third is we need to work together. These problems are way too big for any one person, for any one organization, for any one part of the government. We've got to collaborate. We've got to work together. This is the public health approach based on science, focused on prevention, and collaborative by necessity. So in 1983, when we started looking at violence as a public health problem, we said, let's look at another big injury problem, and that was car crashes. In the 1960s, car crashes were killing a lot of young people in this country. It was an epidemic, and the government said, whoa, this is unacceptable. We've got to stop this. And the government said, we're going to invest money in science. We're going to invest money in research. This was 1970. They invested $200 million. And they said, we're going to do research to keep young people from dying on the highways in car crashes. And they started the National Highway Traffic Safety Administration. And every year since 1970, the government has spent $200 million on research. And what do they get for that? They totally redesigned cars. When I learned to drive on a little red Ford Falcon with my grandfather, cars were designed so that the engine block in a front-end collision would come into the passenger compartment and crush you like an anvil. From research, they learned to change that design. Now the engine block of our cars crushes like an accordion to protect you. The steering column was a solid piece of steel that would spear you through the chest in a front-end collision. Now it collapses and the steering wheel accommodates you. It prevents you from being damaged. They developed side impact collision protection. rollover protection, rear end protection. They developed seat belts. They developed front airbags, knee airbags, head airbags, elevated brake lights, automatic brake control systems. They totally redesigned the car with that research and with the findings, not all at once. There was no one magic bullet to redesign the car, but incrementally and over time, bit by bit, they have saved from that research more than 600,000 lives. 600,000 lives have been saved because we invested in that research. So we got to CDC and we said, how much have they invested in saving lives from gun violence? And do you know what the answer was? Do you know how much the government was spending? Zero. Zilch. Nothing. We said, let's start. Let's see what will happen if we bring science to bear on this. This is the public health approach. And it shows that there are basically 4 questions that we ask. When we say science, bring science to bear, it doesn't mean rocket science, science that you can't understand. It means we ask 4 simple questions that anyone can understand. What's the problem? Who's getting shot? Where? When does it happen? What's the relationship between the shooter and the victim? With what kind of gun? Where does the gun come from? And are these increasing or decreasing? What's the problem? The first question we've got to ask. The second question, what are the causes? What's the role of gangs? What's the role of drugs? What's the role of alcohol? What's the role of domestic violence? What's the role of mental illness and depression in some shootings? But what are the causes? What's the cause of too many guns easily accessible to children at home who may shoot their sibling? Easy access to kids in gangs? What's the role of too easy access? But what are the causes? That's the second question. The third question is, what works? What is effective in preventing these? Will it really work if you arm every teacher in school? Is that going to save the lives of kids? Or will some kids grab a teacher's gun and start shooting? Kids are impulsive. Kids are angry. What will happen if you arm all the teachers? How do we know? How do you find out? You try it. You test it. You do the research. You evaluate it. There's no other way to know. And we put politicians in this horrendous position. We say, well, you sign on this bill that says every teacher can carry a gun to school. The teacher should say, is that going to help us or hurt us? It's going to save lives or kill kids. We don't know. There's only one way to find out. Do the research. And the fourth question is, once you find something that works, how do you scale it up? How do you do it throughout a city like Atlanta? How do you translate it into policy, into practice? What does it take? What are the obstacles? What are the barriers? How do you work with politicians to get something implemented and done? So this is what we mean by science. What happens when you try to go without science? Well, back again in the 1960s, women were suffering when they were pregnant. And the things that they suffer from are insomnia, they can't sleep, and they suffer from nausea or morning sickness. A drug company in Europe said, we have discovered a miracle drug. This drug cures both insomnia and morning sickness. This is going to be a miracle for women. And they went to certain countries and they said, will you let us sell this drug in your country? And they said, yes, we really need this. And in fact, Germany was so impressed by what this drug would do, they sold it over the counter. You didn't even need a prescription. And they came to a woman physician, again, women and the important role that you play. They said, will you let us sell it here? She worked for the FDA. She said, yeah, show me your data. Show me that it's safe and show me that it's effective. Show me that it works. And then we'll let you sell it here. And they said, well, we don't have that data. She said, go home. And you come back to me when you have the data. You show me the data. But until then, the answer is no. And they said, come on. They came back again. And they said, now look how many of these drugs are being sold in Germany over the counter. Look at these testimonials from women who can sleep and go through a day without vomiting. Look at how good this is. She said, that's not data. You show me the results. Prove to me that it's safe and effective, and I'll let you sell it. They went home. They were pissed. And they came back again and again and again and again. 7 times they came back, and 7 times she said, show me the data. And by the 7th time, the results were coming out in Europe that women who took this drug were having babies born without arms, without legs. The drug, thalidomide. She saved this country from a disaster by insisting that we go with the science. Could some of these interventions people are suggesting for guns? You let everybody, Mr. Governor, carry a gun in the state, even without a permit. Could that result in a disaster? Do we know? Should we be passing laws when we don't know what the effects will be? Or should we be thinking that we would do what Dr. Kelsey did at FDA? First, do the science, show me the data. So at CDC, we started to do research. We said, let's bring science in. It accomplished miracles. Let's bring it in to this question of gun violence in this country. And we started funding projects. And the NRA didn't like it. They thought this wouldn't be good for business. And what they told the people in Congress was, if you let them do this research, it's going to end up in all of you losing all of your guns. Was it true? Absolutely not. But this was the myth that they perpetrated. This is what they told people. And they started attacking us. They started calling CDC and the research we were doing the cesspool of junk science. Some people say, well, that's a sign of you're doing the right thing when you get them so angry. It wasn't easy to go on and to carry on. And the very first study that we funded, the extramural research study, looked at this question: does having a gun in your home make you safe? Does it protect you and your family? Because the NRA that exists to sell more guns had been advertising. They said, if you're a real man, if you're a man, you'll have a gun. If you care about your family, you'll have a gun. So we did this study, and we asked, does having a gun in your home keep you safe? And the answers suggested not only did it not keep you safe, but it put your family at risk. The risk that someone in your family would be killed with a gun, with a homicide, went up 3-fold. 200% increase in risk. Now, is 200% increase in risk big? Well, I'll tell you, if you develop a new drug and you go to the FDA and you say, I have a new drug that I'd like to sell, they'll ask you, but are the side effects worse than the drugs that are currently being sold? And if your side effects are worse by 20%, no, you won't be able to sell that drug. 20% is a very big increase in risk. This increase in risk by having a gun in your home was not 20% or 30 or 80 or 100 or 150. It was 200% greater risk. And the risk that someone in your home would kill themselves, suicide with a gun, went up 5-fold, a 400% increase in risk. And the NRA didn't like that. They thought this won't be good for business. And so they wanted to put us out of business and shut down the injury center at CDC. And they got a congressman from rural Arkansas, a congressman named Jay Dickey, to attack us. And Dr. Satcher and I went to Washington to an appropriations hearing in 1996. And at that hearing, we were ambushed. Congressman Dickey asked us questions. He read data that they had made up that was falsified. He took quotes that we had said out of context or not exactly what we had said and questioned us about it. It was really bad. And a big battle ensued in Congress. Some people said, we need to stop this research because everyone's going to lose all their guns. Other people in Congress said, we need more of this research. And something came out of it called the Dickey Amendment. It was a compromise. It said none of the money that goes to CDC shall be used to promote or advocate gun control. But we weren't advocating or promoting any legislation. We were prohibited already, but it was a shot across the bow. And basically they said, if you do this kind of research, we'll get you. We're going to write a congressional letter of inquiry. If you're a researcher in academia, we'll write to the chairman of your department or the dean of your school or the president of your university, and we'll say, you're promoting gun control. And even though you're not, it may take you months putting together the data to prove you're not violating the law and you're not doing it. Or if you're at CDC, we'll attack you. We'll write to the secretary of HHS. We will get you if you do this research. And that was the Dickey Amendment, and it had a chilling effect at CDC. It was really awful. As long as Dr. Satcher was there, he said, we will have your back. We'll protect you on this. This is the wording of the Dickey Amendment. None of the funds shall be used to promote or advocate gun control. Jay Dickey and I came out of that hearing. I thought we were arch enemies, mortal enemies. I hated him. Hated him. I had dedicated my professional career to working on preventing people from being killed, and he wanted to stop us in our tracks. And my bosses, my handlers at CDC, not David Satcher, but some people who worked for him, they said after that hearing, Rosenberg, don't you ever go talk to that congressman. It'll be like throwing a match on gasoline. You understand me? Yes, boss. About a month later, we got a request from his staffer who said he wanted to go over the data that Dr. Satcher and I had presented at the hearing because he was intrigued. Mr. Dickey wanted to understand the science. I thought, that's a good thing. And they said, okay, you can go. You talk to the legislative assistant, but under no circumstances do you talk to the congressman. Do you understand? Yes, sir. So I went up there. We spoke. I had a very nice conversation with the staffer. He really wanted to understand the truth. That always impresses me. And by the end, I was feeling good. And he said, oh, by the way, the congressman is in his office next door, and he'd like to say hello. And I said, oh, shit, this is really, really bad. Either I say, no, I'm not going to talk to him, and I'm rude, and I really throw a match on the fire, or else I go and talk to him and I get fired. I didn't know what to do, but I decided it's probably better just to go in, don't talk about guns or CDC, just be nice, say hello. And I went in and talked, and I saw on his wall that he had pictures not of his awards and legislation, not his victories, but of his family and of his kids. And we talked about his kids, and they asked me about my kid. And the next thing I knew, he had invited my son and his whole class to visit him and gave them a tour of Congress. And then I did something for his daughter who had just moved to Atlanta. I helped her find a job, and we started talking. We actually started to trust each other a little bit. We started to like each other. And with time, we actually started to love each other. This man that I had started out as a mortal enemy with, it really developed into a wonderful thing. You can see a little bit of a documentary about this if you Google Guns, a love story. It was in the New York Times last June, but Guns, a love story. And a friend of mine was writing a story about this, writing a book, and when she told me this was the title of her book, I thought, oh, yet another book where we talk about how America's in love with guns. She said, no, silly. That's not what it means. It's about you and Jay. And we actually started teaching things to each other. I taught him about the public health approach, and he taught me that we needed to say from the outset, that we are going to protect the rights of law-abiding gun owners, because they assumed what they'd been told by the NRA, that if we started doing research, everyone would lose all their guns. He said, you need to let people know from the beginning. And we started talking, and we wrote an op-ed for the Washington Post. And we said that you can't figure out what's going to work in your head. This is too complicated. The only way you can do it is doing the research. And we said the research needs to be restarted. And if we restart the research, we can find things that will both reduce gun violence and protect the rights of law-abiding gun owners. There are things that fit that set of both conditions. It's too complicated to solve two simultaneous equations in your head, but we can do it. And there are things that work. And we said there are things that work. And Jay said it was a mistake to have done anything that would cut down on the funding for this research. Examples of this are universal background checks that keep guns out of the hands of people who shouldn't have them, but don't interfere with the rights of law-abiding gun owners. Waiting periods, people who commit suicide. Most gun deaths are suicides. Between half and 2/3 of gun deaths are suicides. And people who commit suicide, especially young people, are impulsive. Many of them have been thinking about it for how long do you think people are thinking about it on the average before they do it, young impulsive people? No, you hear about old people who think about it for days, months, and weeks. It turns out in a study of young people who attempted suicide but narrowly survived that they'd been thinking about it for 5 minutes. And the idea is if you can keep them from acting on the impulse when they have it, the impulse will pass. So waiting periods, universal background checks, red flag laws that let a judge take the gun away from someone who is threatening to shoot themselves or to shoot someone else. It's done in a judicial proceeding, and then the person, when they're no longer a threat to themselves or someone else, get their guns back. There are things that work. There are things that do both. We just need to find those things. The Dickey Amendment brought about a chilling effect. The amount of research that was done on gun violence at CDC fell by more than 90%, starting in 1999. I got fired from CDC in 1999. My protector, David Satcher, was called up to Washington to become the Surgeon General and the Assistant Secretary for Health. And someone was appointed director of CDC who I had thought had been my friend for 25 years. But I think he caved into pressure, political pressure from the NRA and Republicans to get rid of me and to try and stop the work that CDC was doing. This was in 1999. And for 20 years, basically, the federal funding of gun violence research was stopped. It was stopped. If research on heart disease or cancer or diabetes was stopped for a day, there'd be such an outcry. How can you do this? How can you let that happen? But research on gun violence, do you know why they could let it stop? Who are the people who are primarily affected by gun homicides? Young Black men. Do they have a lot of clout? Do they have a powerful lobby in Washington to restart the research? Absolutely not. The other group, people who commit suicide with guns, are mostly people with mental illness who too don't have much clout or much voice. They're stigmatized, they're isolated. They don't have much clout. And David Satcher said, we're not going to stop this research because it's the job of public health to stick up for people who need our help the most, the vulnerable, the displaced, the people without a voice. That's our job. That's our very job. And we're going to do it. And he did it for as long as he stayed at CDC. But then someone else came who didn't have that commitment. As a result, and the next slide shows, what do we know for sure about what kind of interventions across the bottom work for what kinds of gun violence across the top? And do you see what the predominant color is? Gray. Gray means we don't know. We don't have a clue as to whether these things work. Most of this is gray. We haven't done the research. It was stopped. It was stopped for 20 years. The only things we have strongly suggestive data for are locking up guns at home in a gun safe unlocked so kids can't get them. That prevents kids from shooting their siblings or their parents or themselves. We have pretty good evidence for that. But for nothing else, for nothing is there strong evidence because the research was stopped. It was stopped for 20 years. Jay Dickey and I said, we've got to go back to Congress and get them to restore this research because it was a mistake to stop it. We kept going for a while. We need Republican support and Democratic support. We need bipartisan support because we're not going to get the answer overnight. We're not going to get the answer in a year. Like motor vehicle injury prevention, it takes years and you learn bit by bit. Year by year, you learn more that can help you. We need a coalition to bring people together, to work together. And a coalition, I like to say, is like a marriage. It's very easy to get into it. It is very hard to make it work. And there were always used to be people who disagreed with me. They say, I've been married for 10 years and we've never had a fight. I've never had an argument. I've never gone to bed angry. And I used to say, really? That's so different from my experience. Really? And I used to, like an idiot, get into arguments with them. And I finally learned that some people just lie. Jay Dickey died in 2017, but his wife, Betty Dickey, said, I'd like to work with you to get this research restored. Jay had big shoes to fill, but I'll try. Betty Dickey, I don't want to say she had big feet, but she was an impressive woman. And Betty Dickey raised 5 kids, then went to law school, became a prosecutor. And she knew the harm that guns could do. Her father was killed with a gun. Her mother shot him because he was abusive. And Betty, as a prosecutor, carried a concealed weapon because she put bad guys in prison and they threatened her and her family. So she has always carried a concealed weapon. She knows guns, and she comes from rural Arkansas, which is the capital, duck hunting capital of the world. She knows guns. After she and Jay divorced, she married someone she loved. It was just happiness. And this person used to go duck hunting every year with his physician colleagues. One year he got shot in the leg with a shotgun by a friend, and for a year had surgeries, multiple surgeries. Finally, he got the cast taken off after a year, and he had a massive pulmonary embolism and died. So Betty Dickey knows the harm that guns can do. After Betty Dickey worked as a prosecutor, she got a statewide office and then became the first woman Chief Justice of the Supreme Court of Arkansas. Betty and I went to the Appropriations Committee and said, look, the Dickey Amendment doesn't prohibit research. Keep it in place. It gives protection to Republicans who want to vote for research but don't want to be accused of supporting gun control. It forbids the money being used to promote or advocate gun control. Keep it in place. The previous year before we testified, every single Democrat in the House signed up for an amendment to get rid of the Dickey Amendment. The next year, when Betty and I testified, they kept the Dickey Amendment. They passed a resolution to restore the federal funding. And now this is the 3rd year that CDC has some federal funding again to do the gun research. It wasn't just Betty and I. Many organizations, many people testified and supported that. But we got it over the line, all of us together. It's not enough now. It needs to be higher. But hopefully we will get it higher. Next slide. Next slide. And the current director of CDC, Rochelle Walensky, again, a woman scientist, is the first to speak out after David Satcher to say that gun violence is a public health problem and CDC solves public health problems. We are going to address this. The first one, next slide. Next slide. It's just talking about the kind of high conflict where people are so concerned with fighting their opposition, they forget that the problem is our kids being killed. They forget what the real problem is. Gun homicides, I'm going to end with this point, are one of the greatest disparities in health in the United States. David Satcher has dedicated his career to addressing health disparities. And this is one I want to show you here, and my thanks to Jim Mercy for helping put together these slides. And when I was at CDC, young black men were murdered with guns not twice as much, not 3 times as much, 4 times as much, 5 times as much, 8 times as much as young white men. 8 times as much as young white men. Now, that's not the case anymore. We're coming back to look at these overall US rates. Remember, they were off the chart. So the US rates are at the top. The shorter rate that ends on this slide is the rate for Chile, and that ends on this slide. But you can see that the top line is the overall US rate. Then for Black men, Americans, and the third line down is for white male Americans. And you can see that these overall rates go on. Look at that slide that ends. That's for US males. That rate ends here on the second slide. Look at the numbers in the bottom right-hand corner. And that shows you the bottom rate on that slide, which may be hard to see. But again, these US rates are off the chart. And you've heard the saying that to understand what's happening, you need to follow the money. You've heard that slide, follow the money. It's a good saying, it's true. What we're going to do here is follow the numbers. Watch those numbers in the lower right-hand corner, because these rates there for Americans overall end here on this slide. But the rates for young black men, let's watch what those rates do. Remember, all those other countries are over in the past. All those developed countries are done. But these rates, so I need you to go with me, because we're going to go through a few slides. They go on and on. It's up to 13, and on 15, and on 18. You're getting bored with this? This is really bad. This is really bad. And on 20.5, and on, these are the rates for young black men. And on, and on, and on, 30.5, and on, and on, and on, and on, 40.5, and on, 45.5. Remember, Chile ended at about 2, the next highest country, and on, 47.5. This is where the burden is. These are the men who pay the price. The price of gun violence recently was estimated to be $577 billion a year in this country. Who do you think pays? It's young men of color. It's families of young men of color. It's communities of color. The attention goes to the mass shootings, the school shootings, the workplace shootings. which are a small, tiny fraction of the shooting deaths. Between 1% and 3% get all of the attention. And this is where the problem is. This is who pays the price. This is who pays. Let me conclude that this friend of mine, Paul Farmer, said, the root of all evil is the belief that some lives are worth less than others. The root of all evil is a belief that some lives are worth less than others. Here's the big picture. Take these away. Gun violence extracts an intolerably large price from the country as a whole, but especially on communities of color. We can solve this problem. We have the tools, we have the science that can get us out of this. You'll hear about that science. It's exciting. It's restarted. It's coming back. We need it. There's this deadly myth that if you do research on gun violence or policies affecting guns, everyone will lose all their guns. It's a myth that's killing us. It's part of this high conflict. It's horrendous and not true. The burden is not distributed equitably. Remember these slides that go on and on and on and on. Remember the price we're paying. We can't give in to fatalism. We can't give up. We can get out of this. We can find our way out of this, and we will. You have people like the next two speakers who are doing such important work that will help lead the way. There are short-term solutions focused on guns that we need to implement in the city and the state, but there are also long-term solutions that address the basic causes of racism, inequity, and poverty. They're long-term solutions, but we can do long-term solutions. We did it for motor vehicle crashes. We can do it for this problem. We need to address both. We need to attack both. Thank you for paying attention to this. Thank you for what you're doing, for taking this topic up, and for leading the way. Thanks very much. I'll introduce Joe very quickly. Joe is someone who sustained a near-fatal gunshot injury when he was 17 and went on to devote his life, his career, his time and attention to this problem. Speaks out about it, is both a scientist, a clinician. He takes care of people as a trauma surgeon. He takes care of people who are shot and brought in. And he's doing research, again, the kind of critical work that will help us get out of this. Joe.
Thank you so much, Dr. Rosenberg. And it's really an honor to be here. In fact, I'm going to try to use this. Can you all hear me through this mic? I'm going to put this one down. I do a lot of talking with my hands, so then you won't be able to hear me. Is that okay? Can you all hear me? We're good? Look, I just want to say, first and foremost, I am so grateful to be here with this incredible group, and honestly, a panel of heroes of mine. They are tremendous, and they've been doing this work for decades. So this opportunity is just one that I could not give up. And as you heard Dr. Rosenberg say, I'm on call tonight, so I have to leave early. So I just ask your forgiveness in running before the panel. I want to specifically thank Dr. Satcher, who has been such a tremendous supporter. It's been an honor to be part of his center at Morehouse. And of course, Mr. Joshua Bird and the 100 Black Men. You are amazing. The work that you're doing here in the community is unbelievable. And of course, all the other organizers. Look, I can't begin talking about this issue without starting with my own story. I am the son of immigrants that came to this country in search of those hopes and dreams that I think so many of us strive for. And the one thing that my family never, ever imagined was at the age of 17, I would go from being this healthy high school senior to collateral damage after I was nearly killed after being shot in the throat with a .38 caliber bullet. So I just want to start with the two people, Dr. Bob Ahmed that you had seen on the slide, and Dr. D. Mukherjee, who along with their teams provided me with a second opportunity. When you look at this, this picture up here, the one thing that you'll notice is that all of us, we have people in our lives that love us and that care about us. And the one thing that I think at the age of 17 that I didn't realize, at least, is the fact that you're mortal. And I had no idea what I wanted to do in life. And I remember coming home. I was a couple months after my injury. I had a carotid injury. I had a ruptured trachea. Some of you can probably hear I have a paralyzed vocal cord, so my voice is a little bit raspy. And I was standing in the bathroom. Had a tracheostomy tube at the time. I had these beet red scars up and down my neck. And what I didn't realize is my father was standing in the corner. And I think Pops, looked at me and he saw that look of devastation in my eyes. And he came in and he said, "Joe," he said, "listen," he said, "there's two options here. Number one is you can feel sorry for yourself." And I think that's tough love, especially from an immigrant dad. Or the second is you can take this terrible incident and turn it into something that impacts the lives of other people. And it was that moment that really inspired me to go into medicine, inspired me to become a trauma surgeon. And what I didn't realize at the time, while all of these incredible folks were doing this incredible violence prevention work, is that, while I went into medicine to give other people the same second chance that I was given, perhaps the most important aspect of what I'm doing now is trying to work at the intersection of medicine, public health, and public policy. Because as we heard Dr. Rosenberg say, the best medical treatment is often prevention. Next slide. I was fortunate enough to go to Inova Fairfax Hospital and to train there as a general surgery resident. And I trained with the people that saved my life. And that's for a whole nother story. And then I went to Philadelphia where I was at Penn, and I really started to understand the systematic approach to care of the injured patient. But it wasn't until I did my MPH where I really started thinking, how do we work on this issue beyond the trauma center, beyond the four walls of the operating room? And as I started to go down this path and this journey, I ended up going to the Kennedy School. And that was a really phenomenal experience. Not a lot of healthcare professionals go to the Kennedy School. But I went there because I really began to see the power and the importance of public policy and political will, and how do you combine all of these together? And when I got to Hopkins in 2016, I really then wanted, and I kept asking the question, well, practically, how does this all come together, And so I ended up getting an opportunity through the National Academy of Medicine and the Robert Wood Johnson Foundation, where I spent a year in the U.S. Senate. And I spent a year in the office of Senator Maggie Hassan from New Hampshire. And for those of you that know the senator, she sits on both the Finance and the Health Committee. And I highlight these two committees because these committees control pretty much all of healthcare legislation in America. And what was interesting is I joined right before COVID. So all of our plans of the things that we were planning on working on pretty much got derailed as we focused on this other public health crisis that we faced. I just want to say that I'm grateful for the mentors that I have that have been there through the thick and thin. We wouldn't be here without them. One of whom I think many of you are familiar with, Daniel Dawes, who is just an incredible leader and has been such a foundation for what's happened at the Satcher Health Leadership Institute, and now is going to do incredible work at Meharry. I just want to point out that I do have a couple disclosures. The first is I'm a survivor of gun violence, and I put that on there as a disclosure only to say that as a survivor, we have to recognize our own implicit bias in these conversations. And so I just want to recognize that for everyone. The second is I'm the vice chair of the board of directors for Brady United. And maybe like some of you in here, I care for injured patients. So this is incredibly personal. So I was a firefighter in college, and I show this picture often because I think, as we heard from Dr. Rosenberg, when we're talking about these very emotionally charged issues, it's so important that we understand all of the vantage points. Now, some of you are probably looking at this picture and probably thinking, oh, look, there's Joe, another photo op as the building behind him burns down. Yeah, I know. But the reality of this is that this was a training exercise, and so we had come out of the building as the next team went back in. So just remember that as we're talking about these issues, we got to understand the different perspectives and aspects of where people come from in order to really be able to move the needle forward. So I want to just show you a recent page that I got. This is a 16-year-old that was shot in the head. And you can see there the fragment. I've kept this very PG, but hopefully we'll make a point. This is the first image of his CAT scan. And what you don't know is this 16-year-old kid that came in was actually awake, talking, alert. And I was just incredibly nervous, and frankly, internally, I was very anxious. And the reason I was anxious is because I knew that with this type of injury, he didn't have much longer before he would decompensate. And what I was trying to do in that moment is I was trying to get this kid to talk to his family, because maybe he only had a few more minutes to talk to his family, and maybe he would never talk to them again. We're going to come back to this at the end. We already have seen the incredible number of deaths, as we heard from Dr. Rosenberg, this past few years. It continues to climb. The other thing that continues to happen is, of course, for the first time, gun-related injury is the leading cause of death in children and teens. I just want you to think about that for a second. It's not car crashes, it's not poisonings, right? It's not cancer, it's gun-related injury. This is what our kids are dying from. And we heard about the different disparities that exist, but let's look at it in maybe a little bit of a different way, similar to what we just saw. When you look at the homicide rate and you start to break it out by age and gender, some of you might look at this and say, oh, well, that's not too bad. It's 4.5 per 100,000, right? This is US firearm homicide rate. Well, when you look at white males, what happens? Well, you see that number goes down. Okay, well, we know that trauma is a disease of young people. So when you look at young white males, look what happens to that number. What happens when we look at black males? What happens when we look at young black males? The disparity is tremendous. Here in Baltimore, over the past 8 years, we've had over 300 homicides per year. That doesn't include the non-fatal injuries. And I mentioned the non-fatal injuries. Why? Because for every death, conservative measures are about 2 to 3 non-fatal injuries, depending upon the institute that you're a part of, right, or the state that you live in. And that's important because we know in those people that survive, about 40% are going to be back within 5 years. So those individuals provide an opportunity for us to intervene. And you can see that in Atlanta, there's been over 160 homicides last year, and that number for the past 3 years has continued to go up. Now, we heard a little bit about the mass shootings, and we see that that also continues to head in the wrong direction. And of course, I just want to say that, you know, we need to, of course, stop the mass shootings. But as you heard, this is just the tip of the iceberg, right? Every day in cities like Baltimore, Philadelphia, Chicago, Atlanta, we have young black men that are being slaughtered on our streets. And we have both the opportunity and the responsibility to tell those stories. This also impacts healthcare. I can tell you, April 1st of last year, I was coming in on call. And at 7 a.m., exactly on the dot, I get a call from one of my partners. And he says, Joe, he says, listen, our partner has just been shot. One of the trauma surgeons that works in Baltimore, right, that's taking care of patients. He's just been shot, and he's on his way into the trauma center. What I can tell you is that internally, I didn't know if I was going to be able to separate the emotion from the business of having to make one methodical decision after the other to save this person's life. And I'm happy to tell you that, of course, you know, he survived and physically he's okay, but the mental and emotional trauma, I think, is something that is going to linger on. We've heard about this as, you know, coined as a public health problem, and this is a piece we wrote over 10 years ago. And I show this to say a couple things. The first is, finally, people are starting to come around to the idea and the understanding that gun violence in America is a public health issue. And I've been so, you know, just overly joyed to see folks from law enforcement, from policymakers that are now themselves bringing this up as a public health issue. I think that that's because of people, on the panel and people in this room and people across the country that have continued to push this day in and day out and have helped change the culture over the past decade. There's also this, what I call this myth of mental health. And this is so critical because, every time you hear something, people chalk it up to mental health. And in fact, only 4% of violence is associated with a mental illness. And in fact, people with mental illness are more likely to be victims rather than perpetrators, right? So we have to remember that. Now we know, of course, when you look at different mental illnesses, there is a high correlation with suicide, and suicide is a violent act against oneself, and that's why we include this in the overall public health problem. Now, the other interesting thing that's been happening is that we have seen, suicide is often thought about in older white men. But we have seen the suicide rate among Black, Latino, and Asian teenagers increase by 120% over the past decade. So depending upon how we look at the data, right, it's so critical because there are pockets and demographics that are being impacted. The other demographic are veterans. We know that we lose over 22 vets a day, but did you know that 70% of the mechanism is firearm related? Next slide. And when you think about suicide and why we're even talking about suicide and how it's important, this was a terrific study that looked at those that survived a first attempt. They followed them for nearly 40 years. And what they ended up finding, right, is that those that survive don't go on to die from a second attempt. They go on to die from things that a lot of us will probably succumb to. But if the mechanism is a firearm, you can see that the fatality rate is incredibly high. And here's what's really interesting, is from the time that someone decides to die by suicide till that first attempt, 70% happen within that first hour. So that is why trying to intervene after someone has made the decision is probably too late. And this is why concepts that you heard Dr. Rosenberg mention, like the extreme risk protection orders, are so critical to involve us as a community, as loved ones who know the people around us best. I just want to highlight that 988, the suicide crisis line, came out. This is going to be, I think, a game changer to ensuring that we get people prompt help. Next slide. And then, finally, I'll just mention that this also impacts women and intimate partner violence. And you can see here that if a perpetrator has a firearm, right, an abuser has a firearm, it increases the risk of death by 500%. And in fact, one woman is fatally shot every 16 hours. Now, if the human toll is not enough, I would just say that there's also a significant economic impact. This was a study that we published in Health Affairs a couple years ago, looking at the hospital charges of people that were coming in and being discharged from the hospital and those that were being admitted inpatient. You can see those mean charges, and we estimated about $2.8 billion toll annually. Now, some of you might be saying, well, I just heard Dr. Rosenberg say the economic burden is $557 billion. Next slide. And it is. And that's the reason there's a difference in this is because you have to break out the hospital charges from the societal cost. So what does that mean? That means people not being able to go back to work, to reintegrate into life, to be on a ventilator for the rest of their lives. All of those different components result in a significant economic impact, and this was the most recent one that we've seen from Everytown. Next slide. So I'm hoping that you're seeing, and I think, of course, we often are preaching at the choir that gun violence is a public health issue. And I'm not going to spend a lot of time on this because I think it was nicely covered already, except to just say one thing. In the 60s and 70s, when people were dying from car crash fatalities, we didn't get rid of firearms. We came up, as you heard, with seatbelts and airbags, and we made roads safer. The point is this, is that we went away from simply trying to focus on changing human behavior, which we know in and of itself is not cost effective, to developing a system that makes it less likely for people to be injured. Now, you can't talk about this without talking about the social determinants of health. And this is so critical because we know that they're responsible for about 80% of health outcomes. Next slide. Now, we've also coined this other term called the political determinants of gun violence. And Daniel and one of our mentees, we thought about this after Daniel's book on the political determinants of health came out. And we said, this is very applicable to gun violence, which of course is a health problem. And the point here is this, is that when you think about the structural violence that's happening in cities, right? And you think about the discriminatory policies of the past, redlining and so many others, right? Only policies can change what policies created in the first place. So, we continue to kind of push this concept and talk about this again in an evidence-based, nonpartisan way, but simply putting out the facts there. Next slide. Now, through the American College of Surgeons Committee on Trauma, and this is kind of the House of Surgery organization, there's been a number of things that have been done to really help push this forward across trauma centers in America. One of which is this iSave group run by Rochelle Dicker. And essentially this group is developed to look at some of the social determinants and how they impact violence. There's currently a pilot across trauma centers looking at trauma-informed care and how we're providing that. But there's a variety of other things, including roadmaps for violence intervention programs. And this is a primer that was created and that's sent out and publicly available for centers to understand how to incorporate this. Now, of course, my good friend Fatima Dreyer, who's executive director of HAVI, has done incredible work of really helping trauma centers and health systems figure out how to incorporate these as part of this process. And I just want to briefly, next slide, just show you kind of the concept here. As we look at the spectrum of care of hospital violence intervention programs, it's of course the initial care that is provided, but then it has to go beyond to really involve case managers and social workers to understand who are those at high risk and what are the type of things that we need to do to ensure that they're not part of that 40% coming back within 5 years with another injury that could potentially be debilitating or fatal. And here in Atlanta, you have incredible work being done. I was telling Mr. Bird that we have, Grady Hospital just down the road that of course is unfortunately incredibly busy, but fortunately for us, really forward thinking and have just revamped their HVIP program. Dr. Randy Smith is really spearheading that. And Dr. Rob Taub, who's there, he's the chief of acute care surgery. And they have been committed to really doing a number of things. First and foremost, making sure that they work with the community. And we're going to talk about that in a second. A lot of people will say, Joe, they said, you know what, we've lost hope. We've lost hope because nothing happened. It took nearly 30 years for us to see the Bipartisan Safer Communities Act. It's just something that we just don't think it's ever going to change. And I'm here to tell you that we shouldn't lose hope. And here's why. Yes, it did take nearly 30 years to see this change, where it was a multifaceted approach, a bipartisan approach. But the thing that we have to recognize is that over the past, numerous decades, people on the panel and even across the country have been part of the cultural transformation that we have seen in cities and states across America. Most governing in America happens at the local and state level, right? And because of that, that has moved the needle forward. We heard, the shout out to young people. Young people have taught us a lot, and they've been part of that effort to keep that, moving forward in the right direction. So I would say a lot has changed from a cultural perspective. That legislation that you saw is a first step, and I say it's a first step because like any complex public health problem, there is no one solution. It requires us to really approach this in a multifaceted way across different sectors, and I think you're going to hear Dr. Mercy talk about this. In Baltimore, we've of course done a tremendous amount of work with the mayor to really try to have a comprehensive plan. Part of the problem that exists is that you don't have different sectors within cities talking to each other. Healthcare systems don't talk to each other. They don't talk to the public health department. They don't talk to law enforcement. All of us need to break down these silos and figure out how we work together in parallel. This is a piece I wrote with some colleagues, Dr. Ravar and Hargarden, in JAMA recently. It was, please. That was part of a compendium of 11 different pieces in JAMA around violence prevention and firearm injury prevention. And Dr. Mercy and I were talking about this before, about the complexity of having an Office of National Violence Prevention. But the general concept here is that we think there should be bidirectional communication that exists between the local and state level and the national level. And one of the reasons that we pushed to have this type of office at the executive kind of level is because we know that it's very hard if you drop in an agency to get coordination among different agencies. But as Dr. Mercy appropriately pointed out, that could then change with different administrations. So I'm not sure we have the right solution, but we're putting thoughts out there in an evidence-based, data-driven way to try to really understand how we can comprehensively approach this issue. So, when I think about what we're facing in America, I put this together because as I started thinking about the different pieces we see, right, the central component often comes back to easy access to a firearm, right? Easy access plus hate, easy access plus impulsivity, easy access plus dementia. So when you think about all of these different, pieces, that to me is this central piece. And that's why we have to approach this from a public health perspective. The other thing we have to do is figure out how to change the culture. We've put together a Hollywood Committee on Guns that is, of course, not focused on taking away guns out of all TV and film, because we know that won't happen. But we know the impact that Hollywood can have on changing culture. We've seen that in smoking, right? If you right now write a script and you send it to Apple and there's an actor that's smoking, it is an automatic rejection of the script, okay? When an actor gets in a vehicle, what's the first thing they do? They put on a seatbelt. That's not a coincidence. Now, is this going to change overnight? No, but we have seen from other different models, like in mental health, where potentially creating a compendium that helps the entertainment industry and helps writers and directors figure out how do they incorporate gun safety into what we do. So instead of putting the firearm on top of the desk, they put it in a safe storage, as an example. More to come. Next slide. So I just want to end in a little bit of a different way. And I know I'm not talking to a room full of surgeons, but I can tell you when I have spoken about this to a room full of surgeons, they kind of look at me funny, especially when I started talking about this 10 years ago. They're like, telling your story, But I hope you're going to see the importance of this. One of my professors from the Kennedy School, Marshall Gans, probably the world expert in public narrative, he talks about storytelling in terms of the story of us, the story of self, and the story of now. And I think here's the point that I just want to make is that if you want to go from purpose to action, right, you do that through emotion. And that doesn't mean being an emotional basket case. That means being able to tell your story. And your story doesn't have to be as dramatic as being shot in the throat. Each and every one of you have a story. And I see a lot of young people, sitting out here, and I can tell you, I sit down with our medical students and young people, and I talk to them all the time about, hey, what's your story? The first thing a medical student on my rotation tells me is, I'm a third-year medical student on the surgery rotation, and I want to go into this. And I tell them, well, that's not your story. You're giving me your CV. By the end of the rotation, it's a completely different answer. And that takes time. You got to peel back those layers. Some of you may have seen this TED Talk by Simon Sinek, but it's called The Golden Circle. And again, I think the point here is that when you look at successful businesses and why they were successful, it's not because they told people how to do something. It's because they got them to believe in what they believe in. And that's the why. Next slide. So from our healthcare profession's perspective, for a long time, we really didn't talk about this issue because we, frankly, some of us were scared. Some of us thought we'd get fired. And what started happening is we started to realize that we as individuals that are taking care of these patients, that are talking to these families, we have a responsibility to have our voice heard. And you see this kind of tagline which says an apolitical profession wakes up. Next slide. In 2018, the NRA came after us and said that doctors shouldn't be part of the conversation. And when I say we, it's not just doctors, it's healthcare professionals across the spectrum, researchers, nurses, techs, right? They said, hey, listen, actually, no, we're a central part of the solution. We're talking to these families, we're seeing these patients, right? We're researchers, we're data-driven. And we actually came out, we were incensed, frankly, and this whole movement of this is our lane kind of grew out of that. But the other thing that happened was all the medical organizations under the American College of Surgeons we're prompted to come together and figure out how do we approach this from a public health perspective. Well, I'm proud to tell you we just had our second summit on this, and the proceedings are going to be published in the next week or two. But what's interesting about this whole thing is when we first met, we were talking about this from a public health perspective. People didn't want to even think of policy. They were so scared, right? And now the central focus or part of the pillars was policy. And I think people are starting to understand that us delving into the world of public policy is not equal to politics. And you can do it in a way that's data-driven, that's evidence-based, that allows you to help policymakers understand what we're facing on the front lines. So, when I was in Philly, we would bring kids in from around the community. They were like 14, 15-year-old, teenagers. And I'd give them a tour of the trauma center. Next slide. And then I talked to them about gun violence. And the first time I did this, they were kind of paying attention to me, but not really. And they're 14, 15-year-old kids. I hadn't told them my story yet. And I told them my story, and all of a sudden, all of their eyeballs focused on me. It was a reaction I hadn't seen before and one that I wasn't expecting. And what it taught me in that moment is I went from being this guy wearing a white coat, right, to someone that could relate to what these kids were facing in their own communities. And I asked them, how many of you in here have either personally or through your families been impacted by gun violence? And nearly every one of them raised their hands. So if you're in public life, Professor Ginn says you have to learn how to tell your own story. But I think we all have to learn how to tell our own story. I just want to leave you with a couple of last things. The first is this, is that when you think about health and you think about the issues that we face, right? Whether it's gun violence or COVID, or maybe some of you are interested in different aspects, immigration, climate change, health is so interconnected into these components. And we as healthcare professionals in general are trusted public messengers. And I think one of the things that we have to recognize is the fact that the community is so critical in anything that we're trying to change from a social perspective. I think for a long time, we've sat in our ivory towers and we go out and we talk to the community and we tell the community what they need to do. Give me a break. Those that are closest to the struggle, right, they know what the solutions are, and they have to be true partners, right? Not just we're coming to them and trying to give them ideas of things they should do. They already know that. And I love what you said, Dr. Rosenberg, about our friend Dr. Satcher and about how he embodies love. Because recently I was with one of the community members at his center. He goes by Uncle T. And he said to me, he said, Joe, he said, you know what we call love in here in the center? And I said, no, Uncle T, what do you call it? He said, time. Because it's the time that he spends with those kids. It's the time that we spend with each other to understand the challenge that people are facing that makes a difference. So I live by these 4 Ps, purpose over position. I think all of us as humans, we have ego, but you can't be driven by ego. And being driven by purpose allows you to stay grounded. You have to be passionate about what you're doing, right? But you have to also be patient. And the problem is that most passionate people are not patient, and most patient people are not passionate. So that combination is so critical. And it's critical because we have to persevere against the challenges that we face, right, in our communities and across the country. And that's how you carve out your own authentic path. So I just want to challenge you to figure out what your story is. And I want to leave you with one last story. I love what I do. Like, what I do as a trauma surgeon is tremendous. And it's just, I'm so grateful to be able to have patients that actually trust you to take a knife to them and to operate on them and potentially save their life. And I realize that, often the best medical treatment is prevention. And as much as I love what I do, the worst part of my job is having to talk to families, having to talk to moms and dads and explain to them that their child that left that morning is never coming home again. And not too long ago, I had a 17-year-old that had a devastating traumatic brain injury to the head. And I went up to the ICU, and we have these clear glass doors in the ICU. And I saw his mom standing at the bedside holding his hand. And I tried to do anything I could, honestly, not to go into the room, because every time I do this, a part of me dies. And I walk into the room, and I begin explaining to this mom. Sorry, caught me by surprise. I begin explaining to this mom the devastating injury. And she began telling me about her son, how he was the first in their family to graduate from high school, which in Baltimore, in the Black community, that's a big deal. He had hopes and dreams of going to college, none of which will ever come true. And as she was telling us this, she looked up at our team, and I think she saw how devastated we all were. And she came over and she did something I'll never forget. She put her hand on my shoulder and she said, "Are you okay?" Now, I just want you to think about this for a second. Here's a mom that just lost her son, and she's asking us if we're okay. It's moments like that which restore my faith in humanity, and it's moments like that which get me to wake up every day to do whatever I can, along with these incredible individuals, to make communities safer. I want to thank my partners who are doing the hard work, and I'll be joining them soon. And I just want to thank all the organizers, please, and my co-panelists. You all are amazing, and it's just such a privilege and honor. So Dr. Mercy, as I think you heard, is the Director of Violence Prevention at the CDC's National Center for Injury Prevention and Control. He also has a PhD in sociology from Emory University, and he has been working on violence prevention over the past 4 decades. I had the chance to be on a panel with him, and I just want to share one quick thing about Dr. Mercy, is that he's not just, there siloed off in the CDC, doing incredible research and work. He's also engaging with communities. And in fact, the CDC has teamed up, and maybe he'll talk about this, with Community Justice Action Fund, to do a host of webinars to really engage the community and understand what are the solutions out there. So I just really applaud his leadership, and thanks so much for allowing me to switch, and again, your forgiveness for having to leave early. Thank you.
Are you guys hanging in there? You have to have a little compassion for me following 2 incredibly passionate speakers. I'm going to get my slides up here and get going. First of all, I want to thank 100 Black Men, Morehouse, and Clark for organizing this wonderful symposium. So important that we have these discussions. We don't talk enough within our own community, within Atlanta, about these problems. We need to be sitting down and figuring out solutions. I also just want to say what an honor it is for me to be on the same podium with Dr. Satcher, one of my public health heroes, Mark Rosenberg, my longtime mentor and friend, and Dr. Sakran, who I've just gotten to know, but is an incredible human being and speaker, as you just heard. I also want to acknowledge Dr. Alex Crosby, who worked alongside Mark and I for 30 years on this issue, and also an incredible expert in these issues as well. Now, one thing that Mark has always taught me is to tell the truth. And I want to start out with this. If locking up people, if enhancing, hiring more police, if investing in police technology, if doing all those things were the solution to violence, we'd be the safest country in the world. But as Mark showed, we're not the safest country in the world. We're not the safest country in the world by a long shot. Please don't misinterpret me. I'm not saying that law enforcement is not incredibly important to the solution of the problem of violence. We need to be working together with law enforcement. What I am saying is that traditional approaches that we go to solve this problem haven't worked. In my life, every time in the communities I've lived in the US, we've had a crime wave or a wave of violence, the solution is always to go back to those traditional approaches that we rely on from law enforcement. Albert Einstein defined insanity as doing the same thing over and over again and expecting a different result. We need new solutions. And that's where public health comes in. 40 years ago, when CDC and public health got into this issue, the words violence and prevention were rarely used in the same sentence. But we began asking a very simple, not so simple to solve, but very fundamental, important question. What can we do to stop violence from occurring in the first place? Or what can we do to prevent violence? That question has spurred 40 years of research, of community engagement, of a variety of activities that have led us to where we are today. And I can tell you that we know a lot about how to prevent violence. There's a lot we have left to learn. We need to know a lot more about the specific issue of the role of guns in violence, for sure. We need more research. We need better data. But we have sufficient knowledge to act now. When you have an urgent problem like this, you act immediately. We didn't wait for perfect science to address COVID. We didn't wait for perfect science to address Ebola. We didn't wait for perfect science to address a whole host of health problems. We need to take action based on the best available knowledge that we have right now. Homicide, I want to begin by just talking about reinforcing some of the information that you've heard previously. Homicide is the leading cause of death among young black males in this country, has been so for at least 4 decades, probably longer. Not cancer, not heart disease, not COVID, not all the things we think of as public health problems, but homicide. One other thing I want to point out that's already been mentioned to a certain degree, and that is what drives the attention to this problem of firearm violence has been mass shootings. Mass shootings, I think, as one of the previous speakers said, account for less than 5% of all the firearm violence that occurs in this country. On an average day in America, over 20 young black males die from firearm violence. That's the equivalent of a mass shooting of unrelated events every single day in this country. We have to start paying attention and focusing on the major aspect of this problem and what part of the population bears the greatest burden. I wanted to say a couple things about the public health approach to build on what Mark had previously said. As he said, science is a basic element of the public health approach. And we believe we live in a cause and effect world, so if we can understand those causes, we can move our way through science to solutions. But another aspect of this science is understanding the community experience, understanding what goes on in the communities most affected by this problem, learning from those experiences to inform what we do, to ask the right questions in the research. So understanding, doing community participatory research, engaging the community as we move forward. Those are important aspects of the scientific approach to understanding this problem. It's not just doing science in an ivory tower, but doing science in collaboration with and working with communities. The other thing I want to emphasize is that an important part of this approach is that it's comprehensive. And I mean comprehensive in 2 ways. One, comprehensive in that it engages many sectors. It has to engage health, law enforcement, education, media. Every sector has a role to play in this issue, and we all need to be working together. And it's comprehensive in another way, comprehensive in the sense that no one solution, no one intervention, no one policy is going to solve this problem. We need to do more immediate things like hospital-based interventions that Dr. Sakran talked about, but also need to address the root causes, the social determinants of violence that impact this problem. I wanted to show you some of the recent data we had and just referred to that firearm violence is increasing dramatically. From 2019 to 2020, we experienced a 35% increase in firearm homicides in this country. That is unprecedented. We don't have records that ever show such an increase in homicides in this country. We don't have records that show such an increase in homicides in this country. This occurred right at the time of the beginning of COVID, right? And that probably played a role. But it was also building, you can see, before that time. Firearm homicide rates were going up. And you can see why firearm suicide rates are higher. The difference between firearm homicide and firearm suicide rates narrowed considerably. Next slide. I also wanted to show something else that's really important, and that's that this racial disparities in firearm homicide increased substantially during this period. What we have noticed over decades is that when firearm homicide goes up, it impacts the black community at a much greater extent than other parts of the population. And you can see that in this case, firearm homicide rates among blacks increased by over 40%. So the disparities that we've talked about, the inequities in the experience of this problem of violence are impacting, are even greater, impacting the black community to even greater extent than they had previously. And even before this increase, we had incredibly high homicide rates, firearm homicide rates compared to other countries, as Mark showed earlier. Next slide. Also want to note that when we look at non-fatal firearm injuries reported to emergency departments, they also increased by over 35% from 2019 to 2020. These data are from a program we called FASTER, and these data are available in the state of Georgia. Well, Georgia is one of the 10 sites that contributed to these data that you see here. But as Dr. Sakran pointed out, the cost of these non-fatal injuries is incredible in terms of long-term hospital costs, the treatment of and care for people who are disabled from these injuries. Something I want to point out that we've learned over the years is that different types of violence are interconnected. These are the types of violence we address at CDC and in the public health field, right? From child maltreatment to community violence, intimate partner violence, sexual violence, the emotional and psychological violence, and suicide. Firearms play a prominent role in community violence in terms of contributing to the homicides that result from those homicides occurring in communities, intimate partner violence, as well as suicide, as we've heard. But the point I want to make is these types of violence are interconnected, that they relate to one another, that a person who experiences child maltreatment is more likely to perpetrate violence later in life. Unfortunately, the way we address violence in society is we silo these issues as if they're separate, but they're very much interconnected. We have to recognize that. We're not going to prevent community violence without also addressing violence in the home. Next slide. Violence in communities starts in early childhood. The experiences that children have, what they learn in their homes, what they see in their communities, the trauma that they experience. These are all incredibly important components that lead to violence. If you look at studies of perpetrators of mass shootings or perpetrators of other types of homicide, invariably they have a history of childhood trauma. We can't expect to solve this problem by just dealing at the end of the problem, when the more proximate issues that occur around this type of violence. We have to start early. One of these areas of research that you may have heard about is adverse childhood experiences. We understand now, and these include things like exposure to child maltreatment, to witnessing violence in the home, growing up in a home with a parent who abuses substances or has mental health issues. That when you look at these issues, these are the types of trauma that children experience, that they can affect the brain and their development, healthy development over time. These are data from England and Wales. I couldn't find a comparable slide from the US, but it just showed you the more of these adverse experiences that a child experiences, the more likely that they are to have hit a person within the last 12 months. Dramatically more likely if they experience 4 or more compared to those who experience none. And look at that. This pattern persists all the way up to persons 40 to 49 years of age, although not as a great of extent. But just to point out, we need to understand how these early exposures contribute to the carnage that we see in terms of homicide and firearm homicide. So I want to start talking and spend the rest of my time talking about the solutions and what we do know and what we should be applying. We have a series of reports it's a terrible word, technical packages or resources for action. These are compendiums of the best available evidence, and you can see we have them for child maltreatment, sexual violence, youth violence, suicide, and intimate partner violence. Again, these things are all interconnected, but I want you to recognize them. If you're interested in any of these issues, these are great resources for looking at what the best available evidence is. What type of interventions, what type of policies are likely to have an impact? So I want to talk about some of these right now. One is addressing the needs of people at the greatest risk. And I think some examples where we have evidence for effectiveness include community outreach programs and hospital community partnerships or hospital-based violence prevention programs like Dr. Sakran was talking about. Some specific examples of these are like Cure Violence. Cure Violence is a street outreach program. It's being used here in Atlanta right now and in cities across the country, in fact, around the world. But what it does, it uses street outreach workers to go in the community, have a real knowledge of what's going on in that community and knowledge of the people there, and actually try to find opportunities to intervene to prevent violence. If you've seen the movie The Interrupters, it's about this program, to interrupt that violence. And it's been shown to be effective in a number of cities around the country. Hospital-based programs. These are programs that can, when a youth goes into an emergency department with a firearm injury, there's 2 things that are possible. One, they could come back later for another injury resulting from violence. And second, they could want to retaliate and continue the violence, retaliate against the people that harm them. These are programs that have the potential to intervene in that cycle of violence. So these are 2 types of programs where there's evidence of effectiveness that can be applied and are being applied in places across the country. We have a lot of knowledge about how to prevent youth violence, strengthening youth skills. These are school-based programs or ways to teach kids social skills that can help resolve conflicts. They have a moderate impact, but nevertheless, they are valuable. Linking up kids with caring adults, mentoring programs, creating protective community environments. I'll come back to that one. Providing quality education early in life. Oftentimes, the things we need to prevent violence aren't labeled violence prevention, but they're providing good education, providing jobs, those types of things. So mentoring programs, after-school programs have also been found to be effective for preventing youth violence. Another type of strategy I think is very important is addressing the locations associated with the greatest risk. And these can involve changing the environmental design, the nature of the environment. The nature of the environment can, in schools and communities, can influence the likelihood of violence. You may have heard of the broken window theory, where researchers have found that those areas which are most dilapidated, have broken windows, are the ones with the highest levels of violence. Safe passages is another one. So one of the approaches that people are using around the country and has been found to be to impact lower rates of firearm violence is called greening. That is creating green spaces, sort of improving empty lots, and actually engaging youth in the process of improving the lots and greening the environment. So these sort of greening efforts create a social environment where people can come out and interact with each other. They feel more safe, and it creates an environment which is less likely to contribute to violence and firearm violence. Safe Passages is an example of a program used in Chicago where they educate and create adults along the pathway from kids' homes to schools, so that kids, if they're in trouble or feel unsafe, can identify an adult who is wearing a special vest that can help them and get them to safety. So it creates a safe passage. A lot of violence in Chicago has occurred around the kids as they're moving to school. Next slide. I want to come back to what I think is fundamentally important, and that's the social determinants of health. We looked at these data from 2019, 2020, and what has been established again and again is this association between firearm violence and poverty. And you can see here that those communities with the highest rates of poverty also have the highest rates of firearm violence. And those with the lowest rates of poverty have the lowest rates of firearm violence. This is a finding that goes back 20, 30, 40, 50 years of sociology and criminology. And one of the things that we've been talking about in public health, and Dr. Satcher was part of a commission that was organized by the World Health Organization to really articulate what is meant by social determinants of health and its importance and relevance to public health. But these are the circumstances in which people are born, grow, live, work, and age, and the systems put in place to deal with illness. It's these social determinants. These circumstances are in turn shaped by a set of forces: economics, social policies, and of course politics. Next slide. We all live in a social ecology of sorts, right? We have our own characteristics and behaviors and attitudes. We're influenced by our family, another level of the ecology, by the communities we live in, and then the social structure and social conditions that we exist within. And these social determinants address those social conditions. And public policies are the tool, the intervention, the prevention strategy that has the most power and possibility for changing these types of circumstances. So another important strategy in this area is to provide economic supports and security for the communities most impacted by this problem. And there are a lot of possible policies that can be used in this area. We need to learn much more about this. But I want to point to policies that involve living wages, inclusionary zoning, which is a counter to redlining. Atlanta has passed a series of inclusionary zoning policies, for example. Paid leave is another example. But the ones that have the most evidence are earned income tax credit. These are tax credits for people who are poor or low income that they can get to reduce their taxes. But we have found these earned income tax credits to be an important policy for reducing things like child neglect, a risk factor for behaving violent later in life. Summer job programs. Chicago had a summer job program. They had a lottery because they didn't have enough summer jobs for all the kids that wanted them. So kids were randomly assigned to get a summer job or not. And that was a natural experiment. And when they looked at those kids that got summer jobs, they were much less likely to be involved in violence, either as a victim or a perpetrator. So it's good to know what works, but it's not enough. I used to think if we could just tell the world what works, we'll solve this problem. But it's not enough. We have to be able to implement the knowledge that we know. We need to create a workforce of violence prevention practitioners. We need people who can be outreach workers for street outreach activities like Cure Violence. We need people that can work in the offices of violence prevention, that have a great deal of wealth and experience in implementing programs. We need a workforce for this issue. We don't have that workforce yet. We need to better synthesize and translate the knowledge we have and get it out to people so they can use it and are aware of it. We need to provide support for those programs in communities. We need to be out coaching. We need to bring together the experts in Cure Violence with the people working in different. This is what Cure Violence does. They go around and work with people, but we need to expand that and do it for each of these types of approaches that I've talked about. And then we need to support the community-based organizations that are working directly in the communities. We need to help them be able to apply for federal funding. Many of them, while excellent at doing the work in the community, aren't adept at develop the skills to apply successfully for federal funding. We need to improve their ability to do that. So you all have, hopefully, how many people have seen the movie Field of Dreams? Great movie, right? And you remember the mantra of Field of Dreams. If you build it, they will come. That was the dream, right? If you build it, they will come. Well, unfortunately, in the area of science, it doesn't work like that. If you build it, they may not know. I got to meet at the end of the Obama administration with Obama's chief person on the Domestic Policy Council on youth. And we had a great conversation, but he had no idea that we had any knowledge about how to prevent youth violence. The most important person in the country at the time in influencing youth policy didn't even know. We haven't done a good job of getting out this information. We can't realize the dream unless we get this information out to the people that need to know. If you build it, they may like the one they built better. There's a lot in this one. We have learned a lot from communities about how to do this work. Many of the interventions and approaches, effective interventions and approaches that I shared with you were developed in communities by community people trying to solve this problem. We need to learn from them, and we need to evaluate it and demonstrate that it actually works. Next slide. If you build it, they will try to come, but the map you sent wasn't written in their language. This speaks to the need for adaptation. You know, what works in Chicago may not necessarily work in Atlanta. What works in rural areas won't necessarily work in urban areas, and vice versa. What works in Black communities may not work in Hispanic communities. We need to adapt this knowledge to address the social context in which we're applying it. We can't expect what works in one place to necessarily work the same way in the other. Having said that, we do need to learn from and build upon what we have found to work in one place and use it in other places. If you build it, they may want to come, but they can't afford admission. We don't have the funding to do all these things I've talked about. Many of the programs that we talk about in this area are incredibly expensive. We need to find more efficient, less costly ways of preventing violence. I've worked a lot around the world on violence prevention. I've seen this done in Africa and other regions of the world that don't have as much money come up with very incredibly innovative approaches. We need to find ways to do this at a level and at a cost that can be applied across the country in every community that needs it. Let me just say that we have a website called Veto Violence, and on this website it talks about this, it gives guidance for how communities can take this knowledge and apply it successfully. And addresses issues like the planning, partnerships that are needed, the strategies and approaches. What strategies and approaches among the ones that I've talked about or others may know are applicable given the nature of the violence in a specific community? Which ones should my community choose among the availability? Adaptation. So these are important things you can find on this Veto Violence website that can help guide work in the community. So let me just conclude by reiterating, this is a huge public health, social problem, criminal justice problem as well. We do have viable prevention programs and policies exist. We didn't talk much about data. We need to create more timely and localized data. We're working with Grady here in Atlanta with Dr. Wu, implementing a data collection effort called Cardiff that takes that data and tries to translate it into action. And also we fund Georgia for our National Violent Death Reporting System and the FASTER data that I talked about earlier. But an important part of this issue is the data. We do need to use science to expand and improve the evidence base. not just what works and what doesn't work, but how science, implementation science, how can we best implement what we know it has the best chance of working. And as I've said and emphasized, we need to take what we already know, given the urgency of this problem, and apply and scale it up. I think that many of the programs that I've talked about are being implemented around the country, but not at the scale that's needed to really change the population level of impact that violence and firearm violence has in our country. Thank you so much for your time.
Let's celebrate our morning speakers from session 1 by giving them a round of applause. Thank you, thank you. And while they are coming up to their positions on the panel, I want to take some time to introduce our moderator for this, now afternoon's panel, Dr. Alex Crosby. Dr. Alex, yes, give him a round of applause. Dr. Alex Crosby was raised in Detroit, Michigan. He is the son of Emerald and Corinne Crosby and is a husband and father of 4 children. He graduated with a BA in chemistry from Fisk University, an MD from Howard University's College of Medicine, and an MPH in Health Administration and Management from Emory University School of Public Health. He completed training in family medicine, general preventive medicine and public health, and epidemiology. He worked at the Centers for Disease Control and Prevention for 30 years and responded to public health emergencies, addressing suicide clusters, civil unrest, school-associated violence, sniper attacks, firearm-related injuries, hurricanes, Ebola, and coronavirus. He has authored or co-authored over 125 publications, and his work focuses on prevention of suicidal behavior, child maltreatment, intimate partner violence, interpersonal violence among adolescents, and assault injuries among minorities. He serves as a professor at the Morehouse School of Medicine. Thank you, Dr. Crosby. I'll let you take it away from here.
Well, thank you for the introduction. Thank the sponsors for putting on this symposium today, and some of what we will learn and some of where we will take the action for what we're going to do after today is over. It's Jim Mercy and I were talking about for just a minute that it was almost like a reunion. All of us have CDC in our background and work together at some point in time. So what I would like to do is, I think this is an opportunity. You have heard the presentations from these 3 along with Dr. Sakran, and so an opportunity for you to ask some questions. I'll kind of start off with a few questions, one for each of the panelists, and hopefully this doesn't look like a shy group. I'm just going by what you look like. Doesn't look like a shy group. I don't know if they've got, I see microphone here. I don't know if there's another one over on the other side, but please come on up, make your way on up to the microphone. And if you have some questions for the panelists, I also realize that we are the last thing before lunch. So therefore, we're going to try to make sure, I think 1:15 is what's on the program, that it's time to break for lunch. So we'll try to make sure that we adhere to that. Let me go ahead with the first question while folks are kind of making their way to the microphone, and I'll ask this of Dr. Satcher. We definitely heard from Dr. Sakran along with from Dr. Mercy about social determinants of health and how those can play a role in what we see as the risk factors for violence, but then also how they may be able to play a role if we address them correctly in the prevention of violence. You had a big role with the World Health Organization in terms of social determinants of health. I don't know if you could comment a little bit about social determinants of health and maybe where you see that connection with the occurrence of violence, but then maybe also with prevention.
Well, thank you. I think social determinants. Does it sound like it's on? I think social determinants of health, obviously can play a major role in terms of public health policy and public health implementation. money, for example, is a major social determinant of health. And it's been shown over and over again that it can make a difference. So that means that the way people behave in their communities is often determined by what's available to them. And we especially looked at high schools and junior high schools when it came to things like food, having food available, whether or not there were free lunches. It was interesting, I've told this before, but some of the situations were interesting in that when we took, you can either label the availability of food based on, this is for people who, who fall below a certain income or what have you. But it was really when you took that away and just said, this is for people who need, food or who would like to have the food that's being served, that totally changed their response. So on the one hand, there's an issue of what's available. On the other hand, is how we display it.
Very good. Dr. Rosenberg, you of course have written a number of opinion pieces, in newspapers, as well as, interviewed by the media regarding, some of the strategies for intervening in regards to violence prevention. I don't know if you maybe want to comment on what you see as some of the most critical pieces that maybe the United States or maybe the state of Georgia need to start doing in regards to preventing violence and addressing the issue of violence as a public health issue.
Well, thanks, Alex, and thanks for all the work you have done over time and for continuing to do it. I guess when I think about this, do you people have heard of what happened at Uvalde? There was this mass shooting in a school, and there were police officers, school police, city police, state police, who came quickly to the school. And as children were being shot and killed and texting, the kids were texting out on their phones, help us, we're being killed. What do you think these 287 armed police officers were doing? They were standing around. And the people were so incensed that this happened, that people stood by while kids were being shot. There were multiple investigations and people saying this was horrendous, that we let this happen. Well, I think one of the important things that strikes me is this is exactly what we are doing as a country. While young people are being shot and killed, while people in our communities are being killed, we're standing around and watching. So you'd ask yourself, why? What can explain this? Why do we let this happen? And I think there is among politicians a very big fear of addressing the problem of guns. People are scared to death to address it. Again, there's this myth, that the NRA perpetrated. If you do anything, Mr. Governor, Mr. Senator, Mr. Representative, Mr. Mayor, if you do anything to address the problem of guns, you're going to lose your job because we're going to vote you out of office. It's a scary myth that's not true, but it results in our standing around. It's not the only thing that results in our standing around. These social determinants of health, I think of it as RIP, rest in peace, racism, inequity, and poverty. And you heard Jim talk about it, Dr. Satcher just talked about it, Dr. Sakran just talked about it, Alex, you have written about it. These social determinants are not equally distributed in our society. Power and a voice, access to the media, access to politicians, control of Congress, These things are not equitably distributed. And so I think here we are as a country standing around while this goes on. I think you saw those slides that went on and on and on and on while we stand around. This has got to change. Jim said we've got to act. We've got to act. It's the time to turn these things into action. This city, the city of Atlanta, is at the crest of these homicides of gun violence. And the cost of gun violence is not just borne by the people who go to Dr. Sakran's emergency room because they're injured and they have medical costs and rehab costs and long-term costs. That's just part of it, the person who's shot. How about the family that gets destroyed? How about the community that lives in fear? How about the young kids who grow up living with violence and end up feeling there's no other way, my life's not worth it? These costs are unbearable, and I think we have got to come together. None of us by ourselves can do it. None. 100 black men, is that enough? No, but it sure is a good start and a very important start. You add the women, 100 black men and 100 million women. Now we can bring about change. So I think this is what strikes me the most, Alex. We have got to change things. Knowing is not enough. We must do. Willing is not enough. We must act. This is a saying from Goethe, a famous German author. And I was talking to a friend of mine this morning. We said we have a Jewish version of the Goethe quote, complaining is not enough. All of us have to stop complaining and start doing. And as Jim said, there are things we can do. There are things we can do now. We've got to get our politicians moving. They need to be as afraid of us as they are of the NRA. They need to be as afraid of us as the pro-gun, gun rights people who vote and control our state legislature. We've got to come together. It's time.
Thank you. Dr. Mercer, you talked a little bit about the technical packages. I want to know if you could elaborate a little bit on kind of the basis for those technical packages. And I know there's been a little bit of work, you described the 5 different ones, about some commonalities between some of those technical packages, the ones to prevent intimate partner violence, to prevent sexual violence, to prevent suicide, to prevent youth violence, to prevent child maltreatment. I think one of the other things CDC has found, like you said, not siloed, but there's some things across those technical packages that probably could work across a number of different aspects of violence.
Yes, Alex. I think this gets to this issue of that experience I had with the fellow on the Domestic Policy Council, not knowing what's out there. And so these technical packages, I hate that term, technical packages. We've changed it to resources for action now, I think. But the idea is to get this information out, to translate this science so that people can know about it. I don't think we do a good job of that at all at CDC and in the rest of society. We know a lot more than we share and get out to people that really need to know it, and we need to do a better job. And as Alex referred to, there are interconnections across these. These economic or policies that address social determinants have influence on almost all types of violence. But not only violence, other public health problems. Poverty, social determinants are a fundamental issue that affects all of public health. It has a particularly strong impact on violence, I believe. So that's one issue that if you look across these technical packages, they address policies that are likely to affect all of these types of violence outcomes, including firearm violence. And also, like, one type of violence affects the other. So if we're effective in preventing child maltreatment, that's going to affect people who are sexually abused are more likely to grow up and be a victim of sexual violence or perpetrate it. So preventing child maltreatment, and particularly sexual abuse, is going to prevent sexual violence. preventing people are engaged in child molestation are more likely to engage in youth violence and potentially in firearm violence. So these different type of violence are connected, and what's in these packages are oftentimes relevant to influencing multiple types of violence.
Thank you. I think we have a question here. Sir, go ahead. Tell us who you are also, and then it doesn't sound like it.
Hello?
Yeah.
Hi. My name is Anthony Green. I am a member of the 100 Black Men of Atlanta chapter, class of 2022. Is it working?
It is, but you may have to get closer to it.
Speak a little louder. Yeah, soft voice. I said, my name is Anthony Green. I am a member of 100 Black Men of Atlanta, class of 2022. My question has to do with mental health. I spent 40 years in the risk management sector, and one of the first clients I represented was Colt Industries back in the 1970s. I think that there is no silver bullet, but destigmatizing getting mental health assistance in our community could be one of the things that makes the biggest difference. You talk about child molestation, all of those issues are associated with the mental health of people. And there's a stigma in our community about getting help with mental health issues. So I'm curious about, do you have any out-of-the-box thinking, ideas? I have a few that I'm going to try to introduce with the 100 about trying to address that and how you think that might be helpful in addressing gun violence. Thank you.
Thank you for your question. I'm not sure who wants to take it on first, but I was also thinking Dr. Satcher, while he was the Surgeon General, the first Surgeon General's report on mental health, and maybe you can start it off, and then if the rest of our panelists will also like to comment on that.
So, very important point. And it's one of the reasons that a lot of people don't seek help for mental illness of various kinds. It's one of the stigmas that we talked about in the report. When people, parents, for example, hesitate to seek help for mental health problems for their children because in our community it's often stigmatized. So we need to do more work in terms of educating at the community level, at church, at school, all of the various institutions around us. We need to make sure people understand that just as things go wrong with the heart, the lungs, the kidneys, and the liver, things go wrong with the brain. They always have and they always will. The only question is, how will we respond as individuals, as parents, as communities? And until we answer that question correctly and make sure that people know that we can respond to problems in the brain just as we respond to problems in the heart, and in some cases even better. It's a very important point, and I wish I could say more, but I think I'll stop there.
All right. Dr. Rosenberg?
Thanks, Alex. And again, I want to applaud Dr. Satcher for taking on mental health as an important issue for this country as Surgeon General. It was just one of many important topics he took on, hard topics. 2 points I want to make about mental illness, and I speak as a recovering psychiatrist. The first, I used to do that, but I'm trying to get better, make amends, and do all that. But I think our system for taking care of people with mental illness and mental health problems stinks. It's horrendous. It's really bad. If you've ever tried to get someone to help your kid or to help your partner or to help your friend or your parent, it is so hard. The resources aren't there. The system isn't there. There is no system for mental health in this country. So absolutely, it needs to be improved. We need better resources and we need equity. People need equal access to those resources, and we are so far from it. Second point I would make is that mental illness is used as a smokescreen for all the other problems that have to do with firearms. We have politicians, governors, senators who say that this person who shot 4 people or shot 5 people, they must be mentally ill because a normal person wouldn't do that. It's because they're afraid to address the problem with guns. If you have someone who's angry and resentful and frustrated and scared to death, and you give them a gun, is it a surprise that they might shoot someone when they're angry and upset? It's not a surprise. What's crazy is to think that giving everyone access to guns is not going to result in people being killed. That's crazy. If you got rid of all the serious mental illness in this country, things like schizophrenia and thought disorders, depression, all the other bipolar disorder, all the major mental illnesses, you got rid of all of those. Do you know how much that would decrease violence by? 4%. 4%. And yet you have people who don't want to address the issue of guns saying, oh, it's obviously a problem of mental illness. It's not serious mental illness. Are people frustrated because they can't get a job? Are people frustrated because they don't have access to good education, to housing, to food? Yes, they're mad. They're mad as hell. So we've got to take care of these other problems, but it is not mental illness that's the problem. Should we have a system that helps people when they're frustrated and angry and upset and scared and can't resolve the fights with their kids or their partner? Yes, we need a system that addresses that. But don't go blaming mental illness, seriously mentally ill people. They are not the problem.
Just 2 points in addition.
I see we also got a lot of people have all of a sudden jumped up and want to get in line. So we're
I
going to have to
just
shorten.
I don't want Mark to lay all of this on guns. Now, there are people with mental disorders, you know, and we can treat them. But, and I'm not saying that I agree with just about everything he said, just about everything. But I don't agree that any diagnosis of mental illness, I don't think he does either. But means that somebody is trying to promote guns. That's all I'm saying. We have to be careful.
Yeah, just I think another part of the firearm. I agree with everything that's been said about that mental illness does not contribute greatly to interpersonal violence and firearm homicide. But what it does contribute to is firearm suicide. That issues like depression have a major role as a risk factor for the firearm suicide part of the problem that Dr. Sakran talked a little bit about. So that's important. And another thing that I think people don't fully appreciate is probably the most important risk factor for mental health problems in this country is exposure to violence as a child. Those early exposures or the adverse exposures that can change the brain have a huge impact on the likelihood of a child growing up to experience different types of mental health and illness issues.
Thank you. All right, so since I now see we got a bunch of people standing in line, we're going to have to shorten the answers, shorten the questions. When you come up to the microphone, you probably got to direct your question to one person on the panel, and then we'll kind of move it along a little bit faster. Doesn't sound like it's on. Yeah.
Hello. All right. Dr. Rosenberg, I kind of got from your Terrence Hale, Urban League of Greater Atlanta. I kind of got from what you were saying earlier that the solution is based in science. But and you mentioned research and knowing, but what is, and this is to gun violence, what does the research look like? And how deep does it go? Like, how do we get to the root?
It's a very good question. I think the best decisions come from the best science, knowing what works and what doesn't work, who benefits, who loses from this intervention. We've got to know that. But then it's not science alone that's going to get us the answers, because the best programs come from good management and good leaders and from working together with politicians. We've got to work together with politicians because they've got to take the science and translate it into policy. But I think science has a lot of answers. We know some things that work to prevent suicide from guns. We know things that do work to prevent homicide from guns. But there's lots of things we don't understand. We don't register guns in this country. We register cars, something that's less deadly, but we don't register guns. If we had a system to register guns, would that end up saving lives? If people needed license to own a gun, would that end up saving lives? If we take guns out of schools effectively, would that save lives? There's so many things we don't know if they work. And the only way we're going to find out is by testing them, by having an age of 21 to buy a gun. Is that going to save more lives? By banning assault weapons, is that going to save more lives? We don't know for sure. We think that it probably will, but we've got to test it, especially when you have a country where people are fighting against the other side. We need evidence to convince people. We need to be able to tell politicians what works and what doesn't work. And unfortunately, for most of these types of interventions, for most types of gun use, we don't know what's going to work. That's why we've got to do much more science and make it available for people. I hope that answers the question some.
And I'll just mention too, as the next person comes on up to the microphone, there have been studies that have looked at things like firearm availability and suicides in certain states that have shown there's a correlation between the amount of people that own firearms and rates of firearm suicide going up in particular states. There have been studies, for example, that have looked at things like the Brady Bill, which had, and I think one of our presenters talked about that, Brady Bill had like two main components to it. One was the waiting period, the other was the background check. There were a couple of researchers at Duke that looked at the Brady Bill and said, what kind of impact did that have on firearm-related violence? Well, it turns out the waiting period, that 30 days that you had to wait between applying for it and getting a firearm, that waiting period actually cut down on firearm suicides, but in a certain population. Especially older adult males, they had to wait that 30 days, something else came up, they ended up not engaging in suicidal behavior. So here's some examples in which you can look at a policy, you can look at a bill, you can look at things like firearm availability and find out, okay, how does that impact firearm suicides or firearm homicides? So there are certain ways that you can look at that. The RAND study, which I forget which of our presenters showed it, the RAND study has a number of different things in which it was gray. So that was probably Dr. Rosenberg, a number of different things, but it talks about here are some places in which we can look at those specific policies. How can we evaluate whether they're working or not? So there are ways in which we can look at those specifically. All right, yes, next person. Introduce yourself, direct it to one.
Yes, hi. Excellent program, excellent speakers, excellent dialogue and conversation. I'm an ER doc all the way from Gary, Indiana, and Chicago. I'm also the national chair for 100 Black Men's Violence Prevention Committee for the Youth. One quick observation and a question to Dr. Mercy. First off, as we all see, this room should be filled. And these are the conversations that I see when I attend all these different seminars all over the country. We did a talk at the National Medical Association where I gave a talk and Congressman Benny Thompson was there. And all the docs, it was like 1/4 of us was there. To me, if this is truly a public health problem, we as a Black entity has to be there, have to be present to learn the facts, because we're not there, and we should be showing that support. Yes, without a doubt. My question, Dr. Mercy talked about he had to go all the way to Wales in England to look at a study that dealt with ACE and black kids. We don't have that going on here in Indiana, in the state of the United States. To me, that study should definitely be done because it's definitely needed. And I think it'll bring a lot of information that we could be utilizing to get the funds that we need to continue this battle against trauma in our urban communities.
Yeah, I agree with you 1,000%. Let me say, first of all, that one thing we're trying to do is work with organizations like the Criminal Justice Action Fund and a number of others that have strong connections with the Black community. We're holding webinars, we're reaching out to them, we're trying to generate engagement as deeply as we can with this information and knowledge around the country. And sometimes not everybody shows up. Sometimes the places are packed. So it varies. It depends on the situation and time. But I think there's huge interest in this issue. And I hope that can result in just more substantive action. The data that I showed you from England and Wales wasn't just for Black kids. That was for all kids in England and Wales. But we are integrating those types of questions into the Youth Risk Behavior Survey. So we will have that data for the entire country, hopefully in a number of few short years, to be able to make the same type of points. And not just in terms of fighting and violence, but the way that those exposures to violence early in life affects all sorts of health problems, from mental health, even cancer and heart disease are impacted by those early exposures. So very important data. I'm glad I caught your attention.
Thank you. I'll mention too, since I don't work at CDC anymore, that one of the things that you can do in terms of helping to fund research that is done at places like CDC or National Institute of Health is talk to your elected officials. Tell them we need more money for things like FASTER. I just looked at Ray, I was just there for a minute. In terms of we need more money for this research. And yes, we've really started funding firearm-related research in the past few years, but it's not at the place where it really needs to be. Relative to the other health problems in the United States, we need to fund more. Send your letter to your congressman and senator. We need to fund more of this. Yes, sir.
Good day. My name is Kwame Wilberg. I'm with Friends of the Congo. And I want to thank 100 Black men for this very important forum. Just a quick question. Seems to me that there is enough evidence, enough information out there to find out that access to weapons, for instance, is a big part of the problem. So it's not a lack of knowledge or information. Is it a question of priority, of how important is it that I know today that my wife, my children, my grandson is as vulnerable to violence as anybody else out of those numbers that you presented today, or from state violence? The vulnerability exists, but somehow we go through the process knowing that there's a clear and present danger. Is there a kind of like, I get migraine headaches sometimes and I think, oh, I'm not going to get one today. Is there a weird dynamic going on where we know that there's a clear and present danger, but somehow or the other, it is we accommodate it? And so I don't know, Dr. Rosenberg, or if you could address that.
It's a very good set of points that you raise. Is there a resistance to acting on what we know? And I think there is. I think if these slides that went on and on and on were for young white men, I think we wouldn't be spending pennies instead of hundreds of millions of dollars to find the answers. So I think, yes, I think racism plays a role in how we allocate our resources and our time and what we do. And we're blocked, we're stuck. I mentioned this notion of high conflict. We are stuck where the gun control people think the problem is the gun rights people. And they are fighting each other, and neither one is aware that they're kids. They're not red kids or blue kids. There are kids that are being killed Well, we think it's the other person. We lose sight of it. We become very irrational, and we are really, really stuck that way. And so, yes, people are aware that the more guns you have in the state, the higher the rates of gun homicide, the higher the rates of gun suicide. We have a lot of suggestive evidence that, yes, reducing access to guns will save lives, but we are stuck. We can't pass rational legislation. We've got to move. This is why we need your voices. And I hope you don't get a migraine headache and instead can go and lobby and get your senators and congresspeople to put the resources where we really need them.
Thank you. Dr. McCoy.
Yes, James McCoy, professor in the Department of Medical Education and Surgery at Morehouse School of Medicine. And I want to thank the collaborators who put this program together. My question has to do with two questions. One is, where is the news media for this particular symposium? That's the first. And where is the Black church? Those are the two questions that I have for this particular time.
I don't know if our panelists can actually answer either of those two questions, other than I think part of the point that Dr. McCoy is trying to make is that those community organizations, in terms of the church, businesses, the other sectors, really need to be involved with this kind of thing. And I think our panelists have said some of those things we definitely have to invite them, because if we're really going to talk about this as a societal problem, it takes all sectors of our society to really try to address it. So I think your point is well made, Dr. McCoy. We should have media here, we should have the churches and other sectors from within our society here represented.
Let me add a word about the media. I think the media is MIA. They're missing in action. What happens when there's attention to shooting? There's a big shooting. Let's say it's in a place where all Black people are killed in a store. What does the media do? They say two things. They say, wow, we are really sorry. We feel bad for these people. And we are really angry at this person who shot them. And that's it. No one's asking the questions. Where did the gun come from? How did this person get it? Why was this person so angry? Why were these people so accessible? What can we do? What would work? Does this happen other times? Is there a pattern behind this? There was recently an article in the AJC that listed every homicide in Atlanta over the past year. Did they look for any patterns? Did they say what percent of these were young Black men? Did they say where did the guns come from? What's going on? What are the causes? What's the pattern? What works? The media is missing. They need to be our partner, but we need to get them to do better.
Okay. Next.
Sorry. Hi, I'm Cindy Lubitz, and I work with Morehouse School of Medicine. I have a memory of being in high school when Mothers Against Drunk Drivers became a thing. They were a powerful force in changing our laws, in changing our policy. You know, women are 50% of the population, but we birth 100% of the population. How do we engage the mothers? You know, because every time there's a death, part of that woman died. So how do we engage the mothers as we think about activating policy?
Well, one thing I want to say is that we have dealt with that question on another issue. Every year we have had this breakfast meeting dealing with women's health. And we've invited primarily men, their husbands or what have you. But this year we saw the need to say that we need to make sure that we invite both, because the cardiovascular disease is a disease of both. So I think part of what we're dealing with here is when we try to separate the sexes on an issue on which they're not separated necessarily. We'll
move on, but there definitely are some local organizations, I think Mothers of Murdered Sons. I think there was some organizations in Detroit and some others in which these mothers have gotten together and said, we need to do something about this issue too. So in some cases it can start locally and we can, think about, where might be some applications of that at a state or at a national level. But there have definitely been some that have started at a local level in which mothers have gotten together or parents have gotten together and said, we really don't want this to happen to any other family. So those kind of things do happen.
We have people say a woman's place is in the house. No, we have a mother in the house. Lucy McBath is a mother whose son was killed with a gun, and she had the guts and the tenacity and the strength to persevere, and she is one of our state representatives in Congress, a leader of this fight. So absolutely, we need more women. I hadn't realized that they birthed all of us.
Fantastic. Next, and I know we are already over time, so if some of you are hungry, don't blame me right now. Go ahead, sir.
Dr. Rosenberg, I'd like to present a challenge to you. Can you come up with a curriculum that would be mandatory to all HBCUs that the kids have to go through to maybe form some type of thought process where they analyze where they are and come out on the other side not want to be violent? Because from age 3, kids are killing on the video games, and then they graduate. And then the new thing is a firearm, which is a fashion accessory. And I can guarantee you, I teach, half of the students downstairs throughout the whole Atlanta University Center are going to go buy a Blackie Mile and get high tonight. And everybody that purchases a gun has a certain circumstance that they're going to use it. And there's no way that these kids are going through any conflict resolution. So when they get angry, I'm not going to be dissed. I'm going to do what the rappers say do, and they're going to fire. So if we can challenge the ministers or come up with some, and the other thing is, let's cut off the radio stations. They get hammered with hypnosis 24 hours a day, kill, 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 and devalue the person next to it. So the challenge is on you, Dr. Rosenberg.
Well, first, thanks for what you do and for teaching and standing up and letting kids know how to save their lives. That's really important. Years ago, rap came in for a bad rap, and people said, it's rap music that's making people kill each other. Rap music is really harmful. And then it was video games. They're really harmful. And I think what Jim was talking about here is that what really bothers kids and gets them on a destructive course is not watching it on TV or listening to the lyrics. It's seeing their father beat their mother or shoot their mother or beat them. And it's not just the men who do it. Primarily, it's the men. But it's what happens in the home, what happens in the house. And so we have to educate parents. And we have to educate not just Black parents. It's like telling a woman, we need to educate you how to prevent rape. No, it's the men. We got to teach the men how to prevent rape. It's not just Black kids that need to learn why there's violence here. We need to teach the white kids and the white congressmen and the white governors and the white senators. We need to teach them what's happening and what we can change. So your educational approach is really, really important. We just have to make it broad enough and big enough. So yes, I wish we could support those courses that you want to teach for everyone. Keep it up. It's really important.
And I just add, I fully support those courses as well. And we need to start earlier. We need to start teaching conflict resolution, positive social skills when kids are in kindergarten and on up. And also just to say, social media, when I was a kid, there was no social media. It's a huge influence now. This is something we also need to understand better, how it's influencing violent behavior, how it's contributing to the problem, and where it doesn't. It's an important issue for research as well.
How many people here think social media is a force for the good? How many people here think social media is a force for the good?
Can be, can be, can be.
Well, I just want to see, there was one hand that went up. But it's a mixed bag at best, but something we need to get our hands and heads around much better than we do.
Yes.
Good afternoon, everyone. So my name is Evan Martin. I am a social worker and also program manager with the Satcher Health Leadership Institute. I'm gonna try to keep my questions.
Come up a little bit closer, a little bit closer.
I'm gonna try to keep my questions a little brief. I just have two around this idea of reimagining how we perceive or treat gun violence as, a primary issue and who's responsible for managing it, rather than relying on the police and some of the systems that we have set up here. What do you think would be the role of changing systems that are set up to kind of handle these things, like the creation of offices of public safety or for neighborhood safeties? Are they missing in places like Atlanta or in other places that sort of local jurisdictions? And how can we actually get those things implemented to help with building these kinds of spaces, these kinds of discussions? And then my other question is, it's been referred to a couple of times as the silos in healthcare. Are there actionable things or actionable steps that can be taken to break down some of those barriers? Not just hosting these kinds of, panels or these kinds of discussions, but are there, policy-related things that should be changed or bureaucratic, regulations that you guys have encountered in your practice that prevent more collaboration between doctors, between institutions to actually get a handle on gun violence? Thank you.
One response to your question is, which I thought was a really good one, how do we break down these silos, is essential. These offices of violence prevention are springing up across the country, in cities across the country. And part of their role is to break down these silos. Part of their role is to bring together the health department with the police department, with the education department. So that's one thing. To the extent that these offices of violence prevention can be more broadly supported and engaged, I think that's one strategy for breaking down the silos that you refer to. I think it's a challenging thing at the federal level, and we need to break down silos there as well, because our funding often goes to the Department of Justice or to the Department of Health and Human Services. Rarely is there an attempt in the way Congress meets out funding to require that these different departments work together in trying to solve these complex problems that involve both of the relevant agencies. So it's a big problem. I don't know that I know all the solutions, but I think it's an essential issue to resolve, but in order for us to successfully address this problem.
You mentioned barriers within the healthcare system. How about we provide healthcare to every family, to every child, to every home? Let them have access to healthcare. There was just an article written by Dr. Don Berwick, who said that the structure of our health system is that it takes from the poor and gives to the rich. We have healthcare executives who get paid hundreds of millions of dollars, and yet we have pregnant women in communities in this country, especially in communities of color, who can't get help when they're giving birth. And we have extremely high maternal mortality rates, something that's totally preventable. How about we stop taking the excess profit out of the health system and get a health system that serves everyone, that serves all of us? Oh, there are huge barriers in the health system that contribute to families struggling, starving, being poor, and where the stresses of raising kids are too much for the family to bear, and we start repeating this cycle of violence. So we could do much, much better in terms of our health care in this country.
Thank you. Raina, you have the last question. Introduce yourself and then direct your question.
My name is Rana Bayakli, and I am with the Georgia Department of Public Health. I am actually an epidemiologist. I want to thank you all for as great panelists. I've been working collecting data on the violent death reporting system since 2013. So I'm glad to hear a lot of discussion on data utilization. So we do have in Georgia, we are rich in data, and I would like for every single one of you to reach out to me. It is in my office. You can reach me through the Georgia Department of Public Health. We have our data available on our public health website for both the violent death reporting system. We have created a special initiative with the City of Atlanta. We created a City of Atlanta dashboard that discusses social determinant of health that have been discussed today, talks about health equity, as well as social vulnerability index that were made available by CDC. So please visit the website, as well as we have the FASTER data that Dr. Merce talked about. It is also available on our dashboard. So please go ahead and use the data, and any questions, call the Department of Public Health. You should be able to reach me very quickly once you go on the Department of Public Health website. Thank you.
Can I just
All right, last one.
congratulate the Georgia Department of Health for what they're doing? We didn't talk a lot about data, but data is a foundational type of information that we need to let communities know what's happening right now with respect to violence, and they're doing a fantastic job, not just in collecting the data, but making it available through this dashboard.
Yes.
Okay, my name is Chin Mai. I'm just a normal citizen, former business executive for a major corporation in Atlanta. I just have two comments quickly. And I certainly appreciate the science, the research that Dr. Rosenberg mentioned, because my technical background, I think they are valid, they're great. And I believe that at this moment in time, we as a country have enough data, have enough knowledge, have enough funding to support the research and how to translate that into action. My frustration is, and as well as I noticed that nothing happening. We're waiting for the next shooting, and we said, oh my God, let's count the number. The media come in, count the number of people die every day. But nothing happened. Now, my question is, if we treat it as a national issue, would the creation of a national agency like HSA would help to address this problem? Because me personally, I cannot go longer listening every day in the media, shooting in Chicago, shooting in New York, and then I don't need to tell you guys that, you guys know that. Number two comment I have is, we are sitting on a three-legged stool with one leg missing. We talk about the society issue, we know that on issue we have a challenging issue. We have the challenging issue with the government, with the policymaker. But one of the things, the other leg missing is the business. We need to address that missing leg to bring everybody on the table. Because as long as if we don't address that business-related issue, the company, NRA, you know how much NRA fund on this campaign to the senator that cannot say anything against gun violence? We know all that, right? So we don't address the issue, I don't think we're not going to get any action, any traction to address gun violence in this country. Thank you for listening to me. Thank you, appreciate it.
Let me just say, one of my concerns is that in a gathering like this, people will respond by saying how great it was, but we don't say, where do we go from here? The issue is not the people who are not here. The issue is, what about the people who are here, and what are we going to do? Because we can change. We can make change.
Absolutely. Absolutely.
I think everything, your questions are great questions, but I do want to say this. There is a reason for optimism. 15, 20, 30 years ago, the city of Atlanta wasn't doing cure violence, wasn't doing street outreach. The city of Atlanta didn't have an Office of Violence Prevention. The Georgia Department of Health wasn't collecting data on violent deaths and for non-fatal firearm injuries. Progress is being made. It's much too slow, but there's a reason for optimism. And when you look around the country and see a difference between the way it is now and the way it was 15, 20, 30 years ago. Thank you.
I would say we could also do better. The city of Atlanta hosts CDC. CDC has the world's largest collection of violence prevention professionals in the world. The largest collection of people doing that in the world. And here we have the city of Atlanta that's suffering under this burden of gun violence. They have the potential to work together. They could get the people who work with Jim to help analyze our data, make sense of it. Knowing is not enough, we must do. But you have the potential for partnership here. I don't think we need another agency. We don't need a separate government agency. We need to empower the people who are here. We need to fund the agency that is here to address the problem that's staring us in the face. There's a lot we can do much better.